All right, we're going to get started with our first lunch talk. It gives me great pleasure to introduce, for those who don't know him yet, Dr. Claudio Diaz. I've known Dr. Diaz since my time with Carlos in Philadelphia. He was doing a research fellowship there while we were doing our clinical fellowship, and I've known him over the years and always kind of admired his career trajectory and his body of literature. And the opportunity presented itself for him to join our group. So he's the newest member of our arthroplasty division. He practices not only out of San Francisco, but Redwood Shores, so down in the peninsula, seeing patients there. We kid that the next meeting we need to go to Chile. So keep that on your radar. We'll be going into South America at some point in time. First, we're going to stop in Hogue and then keep on going down the peninsula. All right, Dr. Diaz, welcome to the stage.
Thank you so much for the invitation, Derek and Jeff. I won't start without expressing my gratitude to Eric, to Stefano, to Jeff, to Derek, and Dr. Bailey, and also Dr. Tom Barber. They are being so welcoming, and I'm so happy to be working with you guys. So one of the things that I like to disclose is I'll be showing you the way I face what is called real-life problems and the way I try to tackle them. That's my disclosure. And I will cover four topics. The first one is an introduction to the Chilean public system, the place where I worked, the concepts of disparity in total joints, the concepts of underserved populations, and the way I learned how to assess technology and how to apply them in underserved population. So Chile demographics is interesting. We are a 19 million people country, which number is pretty similar to Northern California. Urbanization is 87%, which is also very similar to Northern California. But interestingly, 8 million people live in Santiago, so it's a very concentrated capital. The education rate is pretty high. 98% of the population are literate, which is a little different compared to other South American countries. Everything started in the pandemics. I became the chief of orthopedics in my department in the hospital of Maipú, which we were 20 surgeons. Maipú is an area in Santiago that covers around 600,000 people, with 7% of them living under the line of poverty. And I started with the literature. I was part of this group, as Carlos and I think Eric was well part of this group, and we create sort of a strategy to reinstall the option of safe surgeries in the pandemics. So how the total joint arthroplasty world works in the Chilean public system. Chile has a hybrid healthcare system. 70% of the people is covered by the insurance provided by the government, which is called the public system. And we face different challenges. Probably the most important are long wait times, limited access to specialized care, and disparity in the quality of care. So what is the Chilean situation in a globalized world? Probably you guys know about this organization. It's called the Economic Organization for Cooperation and Development. The US and Chile are both part of this. And interestingly, this organization considers total hips and total knees are two of the 16 procedures that help to evaluate healthcare utilization among these members. And there are publications. This is a HIP International one. They talk about the growing that we are facing, but unfortunately Chile was excluded from the analysis. So me and my group did a study. We tried to evaluate the utilization rates. We published in the HSS journal, and we found two important things. The first one is that our level of utilization of total joints is below the average, and poverty influences the access. In this graphic, you can see the counties in Chile. On the left side, the counties that behaves like living in Europe, where people has most of the money in Chile, but it goes very down as poverty rates increase. And the other important thing, as you can imagine, Chile is a very long country and it's very concentrated, so geography influences access as well. This is the amount of expenditures per capita among the OECD members. You can see the US in that graphic. In red, you will see the average. In Chile, we are on the right side of the graphic. And this is to make a comparison. The expenditures in health is 8% of the global domestic product for all the countries, but for Chile is below the average, and you can see the difference in numbers there. And this is probably one of the most important things. All of us know about the concept of cost effectiveness, but the range to be cost effective is very different among countries. So in Chile, we are between 6 and 4 or to 5 times more narrow to do cost-effective interventions compared to the US. And I get involved with this concept. I went to the Harvard Business School. I met Dr. Bosick there. I did all the training for this. We start publishing some articles and some chapters. And our reality in a globalized world is disparities in an overall poor surgical access, and we have a very small margin for being cost-effective and improve value. So the first question is how to improve total joint quality of care in Chilean underserved populations. So disparity is the concept to be understood when you're working with underserved population. We know about this concept, all of us. There are some key articles for the residents that are part of the audience to read. And this is a very interesting one by Dr. O'Connor. She interviewed, or they did a survey among the AOA members, and a majority of them see patients who are minorities, and only 35% of those surgeons believe that there is no difference in the way patients receive care based on the insurance or the race or other diversity markers. And we know by fact that Blacks, Hispanics, and Asians have a lower total joint utilization compared to whites in the US. And we also know that Black patients and Hispanic patients have lower expectations and familiarity with the procedures, lower willingness to undergo surgery, and importantly, lower functionality at surgery and more comorbidities. And this is also interesting. All minority patients groups are more likely to undergo total joints in low quality, low volume hospitals compared to white patients. So the first lesson I learned is total joint patients belonging to an underserved population necessitates the surgical team additional efforts to help them overcome the social, language, ethnic, among other barriers. But also, underserved populations are a perfect scenario for disruptive innovations. I know some of you guys are very familiar with this, but this is a very interesting article about innovations. There are different types of them. If you focus on the lower right quadrant, there is disruptive innovation. And this is an article that two great friends of mine wrote in 2009. One of them is in the audience. And you will see the difference between the most demanding and the less demanding consumers. And the less demanding consumers are probably the ones that belong to an underserved population. So after reading this article multiple times, reading all about disruptive innovations, I sent a message to Dr. Bosick, and you can read what was his opinion when I got this position as a chairman in orthopedics. And he said, I think introducing outpatient total joints might be the answer. And we did. And we did this as a different perspective approach. So we hired a navigator nurse. It was the first one, to my awareness, in Chile. We start with overlapping surgeries, the first one in Chile. We start with high efficiency surgeries, which is the thing that I learned at Rothman, and we start with outpatient surgeries. And I introduce a couple of things. For instance, this one that I know Stefano and Dr. Barber do, and I start doing this, and I start doing bikini days because I was convinced that that would help our patients to get out of the bed faster and have faster recovery. But I also read things about fast track and same-day discharge in socialized health care environments, not the US, to get more knowledge. So we get very fast surgeries for our patients. We were the first ones to have a license outside of the US for this OARA score to help you to understand better the behavior of patients undergoing outpatient total joints. And we showed this experience at the Academy last year, and we were able to shorten our hospital stays by 3 days and have significant improvements in the overall quality. And we were pioneers in South America, I'd say, in same calendar day discharge. And this is a patient who I did through a mini posterior approach, never had post-operative rehabilitation. He did it by his own using an app that I will show you later. And he's 2 weeks later, which is something that really helped me to understand that if you do things well, it will help everybody. And this is another important thing that we introduced. Probably most of you are aware of this, but this is a very interesting publication in JBJS. It's called the Perfect Inpatient Care Index. Is the number of surgical admissions with no complications over the first 90 days, with stays that are equal or lower compared to the national average, and the denominator is the total number of joints you do in the same period. And we were able to produce, for the Chilean environment, 92% of perfect admissions for total joints, and we provide 40% more value compared to the #1 private institution in our country. So the lesson number 2 is innovations that may not be significant for the most demanding markets can produce a positive impact among the underserved populations. And the third one is technology assessment, and this is a very hot topic nowadays. You will see in very interesting articles recently how the people is approaching this, how technology can help us to help better our patients that belong to disparities populations. But I would go a step backward, and again citing my good friend Dr. Bosick about the usefulness of cost effectiveness when you're assessing technology and the relationship we have with our vendors. And I'm sorry this slide is in Spanish, but this is a table I created with the American Joint Registry data to tell our hospital what kind of implants we would use. And it's exactly the same one that everybody can use to decide what implant is the best in your hands. And this is the explanation I have to tell you. If you look at the ranges, you will make your own comparisons and you will see what are the performers that are doing better in the American registry, and that will probably change as well as new implants are being introduced in the market. And this is also a very interesting article that I use for my decision making regarding the use of the knee I use, and I use in Chile as well. I'm sorry. These are the surgeon's preference in total knee replacement, and you will see what are the ones that most of the people agree with. And in my mind, the one that is priority is minimization of the operational complexity, and that's why I use the knee that I use. So improvements that we introduce in our practice, we use the preferred vendor alternative that was published by the NYU group back in 2019, both for hips and knee, and we were able to decrease the cost of the implants. We started with telerehabilitation with a platform created in the UK that only costs $10 per month per surgeon, which is something that you should consider to offer to your patients. It's really, really affordable. And I traded the free introduction of a image cup navigator for my hospital by being their official trainer in DA for Latin America, and they put me as part of the group of very preeminent surgeons describing the anterior technique for the standard table for that company. So the lesson number 3 is understanding your options is crucial when you're making informed technology decisions, and you have to ensure that the product features align with your patient's priorities. And this has been working well. I'm happy with the practice I'm getting. It's getting busier and busier. Complexity is also that we face every day, and I will be learning my lessons as well. And I only like to thank you, my partners, and you guys for giving me the opportunity to give you this talk. Thank you.